I'm also a clinical lipidologist, and I work in the Cardiovascular Prevention Center of the University of Bologna. And I will enter in after this two speech with a mildly different perspective that is not very different, but it could be useful to remember to ourselves that we have a classical preventive approach in the most part of the scientific societies that's trying to say that we identify some main risk factors and we try to classify the subject based on these main risk factors and consequently we decide how to treat and when to treat the patient. The main problem is that the cardiovascular risk profile of a subject is always more difficult to be totally and globally evaluated, and the risk is that what we do and what we in part correctly do is to continuously increasing the number of single factors that we try to put in the same line in order to evaluate the global risk of the subject. In this context, now we are speaking about a context that you know very well. The people that working in the longevity field know very well. That is the concept of the exposome. And if we have the habit to listen about the exposome as regards the global aging processes, we have also to consider that there are a large part of factors that contribute to the exposome also in determining the cardiovascular risk and the speediness of cardiovascular aging. And here you see that probably what we call the conventional risk factors are placed in a sort of advanced part of development of our risk, while there is many other factors that we can consider all around, starting from the psychosocial factors, the environmental effects, and even of some contaminants. So, what I try to say that if what Professor Pachin said that is true, and I strongly believe that is true, is that if we wanted to prolong our lifespan with a good quality of life, in the most part of cases, what we have to do is to preserve our cardiovascular health, even because of a main concept that is related to the fact that we can prevent the most part of our cardiovascular disorders while applying a global cardiovascular preventive approach. While we are not so sure to be able at the same time to reduce the risk of cancers or of some neurodegenerative disorders that are or more strongly genetically related or are more influenced by factors that part we don't know, and when we know them, we are not able to manage them. Okay, so it is also ethical to work in prevention of cardiovascular events because we know a large part of the factor, and we can revert these factors. But what is strongly relevant if we consider the exposome that has an impact on the cardiovascular risk and the cardiovascular longevity, it has a very high overlapping with the all-cause mortality risk and consequently inversely related to the longevity of the people. So this is something that we have to consider because if we consider the problem at the global level, and if we consider also a problem related to factors that are not so strongly relevant in our countries, like for instance, problem related to unsafe water sanification that is strongly impacting the survival in certain southeastern countries or in some African countries, you can see that even in that countries, the other classical cardiovascular risk factor impact in a more relevant level on the survival of the population. In this context, even in the European Commission, in the last 10 years, has funded many large and complex trials and studies and projects trying to identify what impact on the cardiovascular risk beyond what we already know and what we are already able to manage. That's like to say cholesterolemia, hypertension, diabetes, and so on. And so there is a large amount of huge investment in trying to understand what are the main determinants of the risk and how we can impact on the risk. I just make some examples. The examples that I will do, they are related to all risk factors that we already know as regards the risk of total mortality that are also strongly related to cardiovascular risk or vice versa. So one of these examples, and about which we are talking very much during the last years, is the one of our exposition to the so-called the microplastics. The microplastics, you know, they are everywhere. The main problem is that we are largely exposed to them, that we were largely exposed for decades, and we have not yet a clear idea about the epidemiology relating the exposition to the microplastics to the final survival rate of the population. And a couple of years ago, there was one Italian study that was really shocking in some way, because this trial was observing the amount of microplastic that we can find in the surgical parts obtained from the carotid revascularization. So what it was observed is that it was that a patient that had no residual of microplastic in the arteries had a prognosis that was largely improved, or better anyway, than the ones that had residuals of microplastics in the arteries. And it was really unbelievable to think that something that is in the environment, like microplastics, could enter in our body. Okay, we can understand that, but what it was really shocking is to find finally the microplastics into the artery walls, and in particular in the atherosclerotic plaques. Okay, so, and the study was published on the New England Journal of Medicine, that is one of the most relevant medical scientific journals in the world. And as Professor Pessin has shown the picture of the center of Milan, I would like also to show you that there are some particular area in the world where we know that there is a high rate of pollution, and we always think to some large cities, for instance, from China or from India. But what you see there are some red area in that European plan related to the PM particles. What is really interesting is that we have invited you to come to Milan for this meeting, and Milan is just located in the most red area of Europe. So, and the competition is just with London, just to say. Okay. So what is relevant is that what we know is that we are studying the relationship to the between the exposition to this environmental exposome to cardiometabolic parameters, and we were able to see that this kind of exposition is strongly associated with an early vascular age in different body districts that were measured with different kind of measurement, starting from the more simple blood pressure measurement to the pulse wave velocity that was cited by Professor Patient also. Another concept in the same area is something that we are speaking also of, largely during the last year, that is the problem of the consumption of ultra-processed foods associated to cardiovascular risk and all causes mortality. All you know that there is a big attention about this concept of the ultra-processed foods, and what is known from large epidemiological studies and the related meta-analysis is that there is a linear association between the intake of ultra-processed foods and the development of cardiovascular events. Where is the critical part of this observation? The critical part is related to the fact that what we call ultra-processed food, in the most part of cases, is something that we already know as junk food related to the typical Western diet, in particular the North American one. There is a very strong overlapping between the consumption of ultra-processed foods and the so-called junk food in some way. So nothing new in particular. The second evaluation was related to the fact that the concept of ultra-processation of the food could not be always related to an impairment of the quality of the food, because there are some foods that are legally defined as ultra-processed that are also associated with no negative impact on human health. In fact, if we see what is the impact of ultra-processed foods in terms of the risk of all causes mortality, what we see is that is not the simple definition of ultra-processed food that make the difference, even if there is a mean effect in terms of increased mortality, but the impact of single specific components and even of specific molecules seems to be more strictly associated to the increased risk of mortality. And here we have, for instance, the sweeteners in particular that support or explain a large part of the negative effect of the sweetened beverages on cardiometabolic risk, obesity, diabetes, and total mortality. And what is also interesting is that everything that is flavoring substances, a number of coloring agents and so on, are strongly related to this increased mortality. Of course, what we have also to note, reading adequately this data, is that this difference in mortality is evident when we compare no exposition or nearly no exposition with very high exposition. And very high exposition is usually related to a global wrong way to eat and to choose the foods, and very rarely to the consumption of the single element of the diet. Okay, so we have also to learn how to read the data, how to understand them, in order to better explain to the patients what really is relevant and what not. Because this is very relevant because there are recent data that show that, for instance, in the Mediterranean areas, in particular in Italy, in Spain, the standard consumption of ultra-processed foods is relatively low compared to other countries, and it seems to have to determine a relatively small impact in terms of longevity. That's like to say that when we speak with patients and we have to explain what is relevant to do, probably it is not so relevant to focus the 90% of our visit time to explain that they have to change this particular part of their diet than, for instance, to take a drug when they have to take a drug or when they have to focus on other components of their risk. For instance, we can have a very healthy diet and we can unbalance the amount of energy during the day. And there are very strongly convincing and increasing literature showing, for instance, that independently from the geographical area when we detect this habit, the skipping of the breakfast per se is associated in a parallel way to an increased risk of cardiovascular disease, of cancer mortality, and of all-cause mortality. This sounds strange in some way, but when we read these data are all adjusted for body mass index, are all adjusted by total energy intake. So there is something that we would probably have to more strictly respect in our biological rhythm, also as regards the intake of food. But if we move from something that is more environmental and behavioral, and we go to observe, to evaluate some parameters, there are some parameters that have some conflicting relationship, or they had a conflicting relationship with cardiovascular outcome and longevity outcome. But one of them that is increasing the level of evidence in terms of association to mortality. I want to say that we are speaking about longevity, so the most part of things that I'm saying is not really related to the risk of events, but just to the risk of mortality, okay? And here we have a conflicting evidence about the association between level of serum uric acid and cardiovascular events. But if we consider the association with the all-cause mortality, the all-cause mortality seems to be strongly related to the level of serum uric acid, and an epidemiological data that is coherent also in different studies is that women seems to be more sensitive to the negative effect of serum uric acid compared to men. Is serum uric acid a risk factor in the strict term? Probably not, because what we see from the intervention trials is that reducing the level of serum uric acid, we are not able till now to observe a reduction in the risk of event or in the improvement of mortality. What is interesting from a biochemical point of view is that the serum uric acid level seems to be more the manifestation of an increased oxidative stress, a systemic oxidative stress marker in our body related to the hyperactivation of the xanthine oxidase. So this can partly explain that. Another systemic molecule that have different interesting effect that we often forget to be related to the risk of cardiovascular events and cardiovascular mortality at the epidemiological level is the vitamin D. Vitamin D, we have also a very large number of prospective core studies that clearly show that they are inversely related to the risk of cardiovascular mortality. Even there we have a problem with intervention studies, because if we consider and we read the meta-analysis of intervention studies, we usually don't find a positive effect, a positive impact of vitamin D supplementation on cardiovascular mortality and on longevity. But why, probably? In the most part of cases, because the most part of trials, of long-term trials carried out with vitamin D has been carried out selecting not so young subjects, because in the most part of these trials have been carried out on patients affected by osteoporosis and some other rheumatological disorders. So there are all the confounding factors that related to the risk factor for the development of osteoporosis, to the systemic inflammation, and so on, and probably because the vitamin D has not a so quick effect on vascular health, so that it's difficult to observe an effect on a relatively short time. But there are a couple of data that are interesting. One of the most interesting for me is this Mendelian randomization studies that have been carried out on the population of the UK Biobank, where the Mendelian randomization is a kind of mixed genetic statistical methodology that can simulate in some way the effect of a long life exposition to a factor or to a treatment related to the final outcome. And what we observed in this nice study, it was that the Mendelian randomization showed that the exposition to the whole life to a higher level of vitamin D, simulating in some way a kind of long-term exposition, is strongly associated to a decreased risk of cardiovascular disorders. And to try to connect with the last speech of this section, I would like to cite another condition that usually is not adequately evaluated in the most part subjects that consider at moderate cardiovascular risk. That is the condition of the obstructive sleep apnea, where the connection with the cardiovascular risk is very, very elevated. It's very elevated for a number of reasons that I will not touch during these my last slides, but what I wanted to stress is that this condition is also associated with an increased risk of all causes mortality and consequently to a decreased longevity. So we have to consider that all the studies that I've tried to show you are in the most part of cases related to large meta-analysis of core studies, and here you can see that to reach this conclusion, there were analyzed the 27 core studies with more than 3 million subjects included. Okay, so the cause-effect association of all these observations are always very difficult to be linked. Why? Because, of course, when we study longevity, there is a main problem, that is that the researcher usually live or survive less than the observed subjects. Okay, this is a main problem, but we have no possibility to do something different than this. But we can arrive to some conclusion. One of the conclusions is also related to the fact that each stimulus that disturb in some way the quality and the duration of our sleep has a strong impact in terms of the risk of cardiovascular disorders, in particular of coronary artery disease, and at the same time to the risk of die for any causes. So I wanted to be very short in my speech, and my conclusive take-home messages could be resumed really in some lines. So that's like to say that, okay, we are always in late. When we speak about prevention, in particular in cardiovascular prevention, we are almost always in late, okay? So we are to be a little bit more in a hurry. We needed to be more quick. And of course, we have to stop to evaluate each single parameters one by one, except with the exception, of course, of some genetic condition or extreme situation. But what we have to remember is that we live in an environment that exposes us to an increased risk to develop cardiovascular disorders since when we are very young, and probably children, and probably even before to our birth, depending on the habit and on the environment of the mother. So it's a very complex situation. Probably we are not able to largely modify this environment, and this is a problem, but there are a large part of aspects that we can dramatically improve, and there are another part that we can improve if we begin to recognize the problems. So, for instance, just asking to the person, but how is the quality of your sleep? That is not so banal, and often is forgotten, but we should do that together with all the other things that we have to do, that are very much, but we are here to do that and to contribute to the cause, to a good health longevity. I thank you very much, and I hope to have created a good bridge. And if you have any question,